If you have any questions, you can type it in the chat. We can address them at the end. Otherwise, I will hand it over to Sarah to take it away here. There we go.
There we go. Awesome. All right, everybody. Well, thank you so much for inviting me to talk with you all today. As she just said, I'm going to be reviewing the 2023 ACC HFpEF expert consensus document with you all today. I did want to give a special recognition and acknowledgement to my mentor for this presentation, Tiffany Gonzalez, who is a cardiology clinical pharmacist at St. John's. So before I get started, I first wanted to state that neither myself nor my mentor have any personal or financial relationships or commercial interests to disclose. To start off with some objectives that I hope to achieve with this presentation, first, by the conclusion, we should be able to understand the diagnostic approach for patients with heart failure with preserved ejection fraction, or more commonly known as HFpEF. We can evaluate the benefit and the clinical considerations for therapy with our sodium glucose cotransporter 2 inhibitors, or SGLT2s. And then lastly, we can identify various medications that have shown benefit in cardiovascular outcomes, specifically with the reduction of hospitalizations for the management of HFpEF. So to start off briefly with the definition of what heart failure is referring to, so according to the American Heart Association, heart failure is when the heart is unable to adequately pump and deliver blood and oxygenation to inadequate stores to the body, and that means it also is unable to keep up with the workload of the body to perform the day-to-day functionings. And then, as I mentioned, because of that, we would not be able to keep up with the oxygenation needs of the body as well. So thinking about the scope of heart failure in the United States, it is associated with a growing healthcare burden in this country, which is largely attributed to the aging population of the United States. So when we think about, our baby boomer generation from the 1940s to the early 1950s, largely that population is turning to like 70 to 80 years of age, where we see the highest prevalence of heart failure at this time. So definitely something we should be aware of in those patients specifically. Currently, there's around 6.2 million adults in the U.S. who are currently living with heart failure, and it is considered to be a major cause of morbidity and mortality worldwide. And actually, the lifetime risk for heart failure at age 40 is around 20%. Now, there's various staging and classifications for heart failure that I will go through pretty briefly, just to kind of give a brief overview and understanding of heart failure itself. So to start off with the classification scheme from the New York Heart Association, or the NYHA, there's about 4 different classifications based on patients' symptoms that they are presenting with at baseline. So to start off with our class 1, this includes our patients that have actually no limitation in any functional activity and can perform any degree of physical activity without experiencing symptoms of shortness of breath. For our class 2 patients, these patients do have some slight limitation in their physical activity, but it is noted that they are comfortable at rest at that point. Moving forward to class 3, these patients do have a marked limitation of their physical activity, and they can experience symptoms by simply just like walking across the hall or walking up a small flight of stairs, but they are relieved by rest with their symptoms. And then lastly, with class 4, these patients will have symptoms regardless of whether they're engaging in physical activity or whether or not they are resting at that point. Getting into the second component with heart failure with the staging, this is stratified based on the patient's ejection fraction that is detected by an echocardiogram, which again, for reference, is about the volume of blood that's pumped out of the left ventricle during systole. And these definitions have actually been updated with the more recent version of the heart failure guidelines that were published in 2022. So I have the different classifications that go along with those updates. But starting off with our heart failure with reduced ejection fraction, or our HFrEF patients. This includes patients that have an ejection fraction that is less than 40%. One of the newer definitions that have actually been included based on the newer version of this guideline was the heart failure with improved ejection fraction group. And this actually is referring to patients who at a previous time had ejection fraction that was less than 40%, but with a repeat echocardiogram, it was found to be greater than 40%. With our heart failure with mildly reduced ejection fraction, or HFmREF, this kind of includes our patients that kind of fall somewhere in between the HFrEF and HFpEF category, meaning they have an ejection fraction that's between 41 and 49%. And lastly, we have our HFpEF patients who have an ejection fraction that's greater than 50%. And so for the duration of this presentation, I'll largely be focusing on this fourth pillar that I have listed here on the slide, especially since we're here today covering the expert consensus document for HFpEF. So most of the content for the duration of this presentation will be on HFpEF. So to get into the specifics with HFpEF itself, HFpEF accounts for more than 50% of all cases of heart failure. So actually a majority of patients that have heart failure at this point actually fall into that HFpEF category. We actually see a higher incidence of HFpEF occurring in women rather than men. And one of the reasons behind this is that women tend to have higher ejection fractions on average as opposed to men. And we actually expect that prevalence in women to rise by about 30% in the upcoming decades. I also wanted to make note that HFpEF is not necessarily diastolic dysfunction. That's something that has been classified with HFpEF patients relatively frequently with some volume overload, and that can definitely occur in our HFpEF patients, but that doesn't necessarily mean that they don't have some degree of systolic dysfunction as well. So I wanted to include that little tidbit of information here on the slide as well, just to provide any clarification with this disease state. But regardless of if patients present with HFrEF or HFpEF, there is significant morbidity and mortality that is associated with this disease state. And we actually see similar outcomes with HFpEF patients to that we would see with a HFrEF patient. Leads us to actually getting into the bulk of this conversation today, discussing this 2023 ACC expert consensus document. And you may be wondering why this document is actually in play, considering we do have relatively recent guidelines that were published as of 2022. And so the reason and kind of the logic behind why this document was created was to kind of complement the current clinical practice guidelines and inform clinicians on new and evolving clinical data that has come about, as there's been a number of clinical trials looking at various medications that could be used to treat HFpEF. And so one of the things that it's seeking to do is kind of filling in the gaps from those HFpEF or heart failure guidelines from 2022. As those guidelines actually focus a lot more on HFrEF, there is some information and a decent amount of information on HFpEF, but this document definitely supplements that very nicely and provides additional information for those patients. So as it is listed here on the slide, there's tips for clinicians to make sure that we are timely identifying these patients and implementing therapy as appropriate in our HFpEF patient population. And one of the big things that they discuss in this document, as well as encouraging multidisciplinary collaboration to improve patient outcomes. And then lastly, this document was developed in part due to that increasing data surrounding HFpEF since we've had a number of clinical trials published in the recent years. So there's actually been a couple of objectives that the document lists in terms of what they're hoping to achieve when this document was published. The first being able to appropriately approach patients who are presenting with symptoms of shortness of breath. They wanted to understand the common diagnostic approach to a patient presenting with HFpEF. They want clinicians to be able to manage and address various patient comorbidities that may be presenting with and addressing those appropriately. They have recommendations for optimizing the guideline-directed medical therapy, or GDMT, that is recommended for a patient presenting with HFpEF. And lastly, they want to provide information for understanding when and why we would need to refer a patient to a heart failure specialist so that those patients can receive a higher level of care. And just for reference, as I'm going forward, I'll largely be focusing on the diagnostic and then the medication management part of these objectives, but these are listed here for your reference. So without further ado, I'll go ahead and start with the diagnosis for HFpEF based on what it states in the expert consensus document. So one of the things that is listed in this document is actually a pretty helpful algorithm kind of outlining how you can think about a patient from the time they present to a clinic with symptoms of HFpEF, and then how we can actually roll in an actual diagnosis of HFpEF. So based on this diagnostic approach that they have outlined, initially we have a patient who's presenting with those common symptoms of a HFpEF presentation, like edema or shortness of breath. Then from there, they recommend assessing for various differential diagnoses and mimicking disease states. They may also present with those symptoms of edema and shortness of breath, since HFpEF is not all inclusive for just having those symptoms. From there, they have recommendations for applying what's known as the universal definition of heart failure, which could be helpful at ruling in a diagnosis of HFpEF, and I'll go through what exactly that entails in the coming slides. And then from there, there's also a couple of scoring tools that are available to assess the likelihood of a HFpEF diagnosis. One of them, for example, as it is listed here on the slide, is this HFpEF score, and we'll go through that as well. And then lastly, when we take all these factors into consideration, this can lead to an overall diagnosis of HFpEF down the line. So starting off with kind of that first main box that we saw after a patient presents with the signs and symptoms of heart failure, which again includes shortness of breath, edema, or exercise intolerance. There's a number of disease states that should be considered or ruled out before ruling in a diagnosis of HFpEF. So a couple of examples of that could be obstructive lung disease, pulmonary embolism, neuromuscular disease. Anxiety may also present with some shortness of breath. Patients presenting with arrhythmias may also have these symptoms, anemia, and then definitely something that's important to me as the pharmacist on the team is some of the medications that may be contributing to those symptoms of edema or shortness of breath as well. So all worthwhile things to consider when going forward with these patients and diagnosing them.
Hey, Susan, can you mute your microphone?
Oh, I just have to figure out how to do that.
It's just a little microphone with the slash through it, I think. Thank you.
Yep, perfect. No worries. Okay, so from there, once we have adequately ruled out some of those additional or differential diagnoses or mimicking disease states, there's a number of imaging studies that patients could undergo that we've kind of already discussed here, as well as some laboratory results. So to start off with that kind of that gold standard imaging that we would use for a heart failure presentation, we would look at an echocardiogram to assess for any structural, functional, or cardiac abnormalities. And again, this echocardiogram would provide us with that ejection fraction, and from there we'd be able to differentiate between HFpEF, HFrEF, or HFmrEF, depending on the value of that ejection fraction at that time. Another thing that is commonly assessed from a laboratory standpoint are these natriuretic peptides, commonly BNP or the NT-proBNP. And these are peptides that are released by the myocardium in response to volume or pressure overload states. Now, just to kind of give a little bit more information on these peptides, they actually have some vasodilatory properties, which can make them actually beneficial in patients presenting with, increased hypertension or increased volume overload to kind of help offset some of those symptoms that they may be presenting with. So it's actually kind of serving as more of a compensatory mechanism for these patients. But if they are elevated, that could be a signal that there's something additional going on. So when we think about what exactly a level for a BNP would be considered elevated, they actually have different levels depending on whether a patient is evaluated in the outpatient setting versus the inpatient setting. So if we see a patient presenting outpatient, a BNP would typically be considered elevated if it's above 35, and then that pro-BNP would be considered elevated if it's greater than 125. Contrastly, if we see patients in the inpatient setting, a BNP that was greater than 100 would be elevated as opposed to greater than 300 with the pro-BNP. So just a couple of things to keep in mind with those peptides when we're evaluating these patients. I do have something noted here known as the Framingham HF diagnostic criteria. This is actually something that was published in about the 1970s to kind of help rule in a diagnosis of HFpEF. They have major and minor criteria listed here on the slide, and I won't go through this too much, but at the time there was certain diagnostic criteria in which if they met 2 of those major criteria or 1 of the major plus 2 of the minor, that could be highly suggestive of maybe a patient's presenting with HFpEF. But again, that's not utilized as much in clinical practice based on what I was able to identify and research, but just something kind of showing you where we came from and where we're going. So that kind of leads us to this newer definition that has been used more widely, this universal definition of heart failure that's actually well noted in that expert consensus document. So this actually consists of a number of components. So the first is that patients will present with those signs and symptoms of heart failure, again, edema, shortness of breath, or exercise intolerance. But again, they would need to have that ejection fraction that is greater than 50% based on the recommendations for classification based on the guidelines. And then from there, patients need to have at least one of the following, and this could be evidence of some pulmonary or systemic congestion, or they may actually see some of those elevated natriuretic peptides with the BNP or the pro-BNP to help lead to a diagnosis of HFpEF at that point. So this is something that we want to apply after we have ruled out some other potential causes of those signs and symptoms. Number of diagnostic scoring systems that have been validated and utilized to help rule in a HFpEF diagnosis. And it's noted that even though that universal definition of heart failure is very helpful in diagnosis, this may be difficult when an echocardiogram does not really show any evidence of structural or functional damage. And are certain circumstances when even that BNP or the pro-BNP may be normal in some individuals when they actually still have some degree of cardiac dysfunction. So with that going on, we could actually utilize some of these scoring systems to further aid in a diagnosis of HFpEF. And some examples of that include this H2FpEF score and then the HFA-PEFF score. And I'll briefly go through these as well, starting with that H2FpEF score. So I'll kind of skip through this a little bit, but as you can see here, they have different comorbidities and kind of patient characteristics that are allocated based on the letter of this H2FpEF. It actually kind of reminds me of our CHADS-2-VASc scoring system that we would utilize in AFib. And there's various points assigned to whatever criteria that the patient is meeting. And according to this particular scoring system, they state that a score that is at least greater than or equal to 6 is highly suggestive of a diagnosis of HFpEF at that point. We also have the second scoring system, the HFA-PEFF. And in this particular system, they have 4 different steps to identify patients with a HFpEF diagnosis. The first being a pretest assessment, which is where you'd evaluate baseline characteristic signs and symptoms as you normally would for our patients, and then address various comorbidities that they may be presenting with, like hypertension, diabetes, and AFib, for example. From there, they have the echocardiographic assessment to look at that ejection fraction. And this also includes looking at some of those laboratory results with the BNP. And then lastly, there's recommendations for functional testing with a stress test, and then ruling in with a final etiology after excluding those potential differential diagnoses. And I did want to mention as well, with each of these 4 components that I have listed here on the slide, there's kind of an additional component to this where there's points assigned based on, their laboratory assessment, whether or not they pass that stress test successfully, or just various other patient-specific factors. And based on the points that are assigned to each of those components of the 4 steps, a HFpEF diagnosis would be suggestive if they had a score that was greater than 5 at that point. And from there, I have our first assessment question to kind of ponder on. So we start off with KW, who is a 67-year-old African-American male who presents after a 2-month history of shortness of breath and bilateral leg edema. This patient's most recent echo was indicative of an ejection fraction that was 55%. And pertinent past medical history includes AFib, type 2 diabetes, as well as hypertension. Now, at that visit, they had a pro-BNP that was resulted at 323, and the patient's BMI is noted to be 33. Now, based on the information that I've shared with you all this afternoon, which of the following are some validated assessment tools that can aid in diagnosing a patient with HFpEF? And this could be a select all that apply situation.
And you guys can put your answers in the chat if
Yep.
you'd like.
Don't be shy, everybody.
nobody wants to answer. Go ahead and give the answers.
Yeah, I can go ahead and give the answers. So yeah, so we've got that universal definition of heart failure, and I see some responses in the chat with C and D. Yep, those are good examples of some of the scoring systems with the H2FpEF score, then that HFpEF score. We also have the universal definition of heart failure, which could be employed in our patients as well with answer A. But again, we have B, CHADS 2 VAS score, definitely not the correct answer in this case, since we would use that more so in evaluating stroke risk for AFib patients. And then we have the HAS-BLED score as well, which would be more so looking at their ultimate risk of bleeding. So yes, good job. All right. So from there, I'm going to go to my favorite part as the pharmacist on the team, the management of HFpEF patients. So kind of give a brief overview of HFpEF. There's been a number of clinical trials that evaluated patients with HFpEF, but initially those trials actually demonstrated minimal benefit in terms of showing reduction in hospitalizations and even mortality as well. I mean, a lot of the previous recommendations in terms of HFpEF management focused more so on symptom management and the reduction of some of that congestion and volume overload, typically treated with loop diuretics. Over the course of the past 5 years or so, there's been a number of clinical trials that have demonstrated the benefits of various guideline-directed medical therapies, or GDMP, that have actually shown great improvement in cardiovascular outcomes. And we'll actually go through some of those clinical trials in the later slides of this presentation. And actually at this time, because of the data that has been supplemented from those clinical trials, there's recommendations that GDMT should be initiated in all patients with HFpEF unless they have certain contraindications to each of these therapies. So thinking about our approach to HFpEF treatment, there's a nice little algorithm in the document as well, kind of outlining which are our preferred therapies and when we could consider adding on additional therapies for our HFpEF patients. So really kind of a main pillar of our HFpEF treatment has actually been the introduction of the sodium glucose cotransporter 2 inhibitors, or SGLT2s. This should actually be initiated in all patients unless they have certain contraindications to use. From there, there's actually recommendations in terms of what we should add based on the overall clinical presentation of those patients. So to start off with an additional kind of pillar here, we have patients who are presenting with symptoms of fluid retention or that New York Heart Failure Association score that's 2 to 4. And at that point, we could consider adding on a loop diuretic for more symptom management of that volume overload. There's actually a recommendation for all women as well as men who have an ejection fraction that is less than 55 to 60% who also are presenting with fluid retention. At that point, we could consider adding one of our mineralocorticoid receptor antagonists, or MRAs. Likewise, for all women and then men with an ejection fraction that's less than 55 to 60%, we could consider adding one of our angiotensin receptor neprilysin inhibitors, or ARNIs. And then if there's some reason where a patient isn't eligible for an ARNI therapy due to a contraindication, or if maybe they're not able to take it due to intolerance or cost, we could consider adding a angiotensin receptor blocker or an ARB alternatively in these patients. And I'll make a point to go through all of these treatments as we go forward to kind of provide a little bit more information on the clinical trials that looked at these particular agents, and as well as some of the clinical pearls surrounding the use of these drugs. So to start off with kind of our main therapy that we think about with HFpEF management, these SGLT2 inhibitors were actually originally studied as some oral anti-diabetic drugs. And when they were evaluating these drugs specifically for the treatment of type 2 diabetes, not only did they find that they improved glycemic control in these patients, but they actually showed a major reduction in the major adverse cardiovascular, or MACE events that we see with patients with diabetes. And from there, they went ahead to evaluate these agents in indications not just with diabetes. And with those particular studies, they found that there was benefit in reducing hospitalization for heart failure across all subtypes. So this can include our HFpEF patients, our HFmrEF patient population, and then HFrEF as well. And based on that new update to the guidelines that was published in 2022, they actually consider our SGLT2 inhibitors to be a class 2A recommendation to be added for our patients with HFpEF at this point. As I mentioned previously, we should be initiating this therapy in all patients unless there are certain contraindications to use of these agents. So I want to provide this brief picture, kind of better explaining the mechanism of how our SGLT2 inhibitors are working. So to kind of orient you to this picture, we have a picture of a nephron. Typically, our SGLT2 inhibitors are working on the first part of this nephron, the proximal convoluted tubule. And there's two different receptors that are present here. The SGLT2-1 receptor, which is responsible for around 10% of the glucose reabsorption. And then we have the SGLT2 inhibitor, where these drugs are working, that's responsible for 90% of that glucose reabsorption. And if you can kind of see what's going on with that particular transporter, we're seeing the reabsorption of both sodium as well as glucose from the filtrate back into the blood. So if we see an SGLT2 inhibitor used, we actually see a decrease in that reabsorption of sodium and glucose, which means more of it will be in the filtrate and more of it will be excluded from the body. So you can see here why it would be beneficial potentially for our diabetes patients, considering we wouldn't see as much glucose reabsorption and we'd see more glucose being excreted. And then also from a volume overload standpoint, since we were not seeing as much reabsorption of sodium, that could potentially be a helpful option for our patients presenting with heart failure. So getting into the SGLT2 inhibitors that we think about in terms of the management of heart failure, the two ones that we see used most often are empagliflozin as well as dapagliflozin. For this indication specifically, they're both dosed at 10 milligrams daily, and there's no dose titrations that are needed for either of these agents. Now, just as a disclaimer, there are different doses with each of these medications that could be utilized in patients with diabetes, but for an indication specifically for heart failure, that 10 milligram dose is what we would typically see for our patients. There is some renal adjustments that are recommended for each of these agents. So actually, if a patient has a GFR that's less than 20 and they are initiated on empagliflozin, they actually have not shown any clinical benefit in these patients. So it would not be recommended to be started in those with a GFR that was less than 20. And then with dapagliflozin, if the GFR was less than 25, there was actually no evidence of clinical benefit in those patients also. When we think about some of the clinical considerations with our SGLT2 inhibitors, definitely some of the major contraindications to using these agents would be any sort of hypersensitivity to any of these agents in the past. It would not be appropriate to recommend these agents if patients are actively receiving dialysis, and it's also not recommended to use in patients with diabetic ketoacidosis or type 1 diabetes based on the information provided in the package insert. The SGLT2 inhibitors also have some various precautions to use. And this can include being cautious in patients presenting with renal dysfunction. And there's also a recommendation to discontinue this therapy about 3 to 5 days prior to surgery, and then monitor for signs and symptoms of dehydration. And one of the reasons behind this is they see in patients that are severely volume depleted or have an upcoming surgery is that there's actually a higher incidence of euglycemic DKA occurring in these patient populations. So definitely something we want to avoid for those patients if we were to initiate this drug or think about initiating them. So when we think about some of those clinical trials that looked at the use of both of these agents, I'll start off with the Emperor Preserve trial, which looked at the use of empagliflozin in our HFpEF patient population. So this study was a randomized, double-blinded, placebo-controlled study that was conducted in patients presenting with NYHA heart failure 2 to 4. And they also had an ejection fraction that was greater than 40%. And I did want to note that this does include both our HFmrEF patients and our HFpEF patients, but actually about 60% of the patients enrolled in the study, well, 60 to 70% fell into that HFpEF category of greater than 50%. And one of the main things that they were looking with this study was various heart failure outcomes with empagliflozin therapy, specifically in this patient population. So they were comparing the use of empagliflozin to the placebo in this case. Looking at the primary outcome that they evaluated in this study, they were looking at a composite of CV death as well as hospitalizations for heart failure. And then a notable secondary outcome would be the total number of hospitalizations for heart failure after patients were initiated on this medication. Getting into our results of the study, they did see a statistically significant decrease with the use of empagliflozin based on that composite outcome of hospitalizations for heart failure as well as CV death, as evidenced by our p-value here. But when we break down this outcome even further to the components of that composite, actually the only one that achieved a statistical significance was that hospitalization for heart failure, as we did not see a significant decrease in our CV death outcome. So really that composite endpoint that we were looking at was largely driven by those hospitalizations for heart failure. And this could be evidenced even further based on that secondary endpoint of total hospitalizations, where we also saw a statistically significant decrease with empagliflozin. Getting into our second trial that we looked at with our SGLT2 inhibitors, this is the DELIVER trial that looked at the use of dapagliflozin in our patients with HFpEF. Very similar design in terms of what we were evaluating as compared to the Emperor Preserve trial. This also looked at patients with chronic heart failure and patients with an ejection fraction that was greater than 40%. And they were also looking at that composite endpoint of hospitalization for heart failure as well as cardiovascular death. Looking at the results of this study, we actually saw pretty much the same result as what we saw with the Emperor Preserve study, with that statistically significant decrease in that composite endpoint, but that was largely driven by those hospitalizations for heart failure. So that was really the main conclusion that they had here, that with the use of dapagliflozin, we did see a reduction in the composite of hospitalizations and CV death, but largely based on that hospitalization factor. Mention some additional clinical considerations that we should think about when initiating our SGLT2 inhibitors. Some of them I'd already mentioned, but again, our patients with renal dysfunction would need potentially some extra care when thinking about whether or not these agents are appropriate, especially with those patients that have a GFR that's around the 20 to 30 range. There's been less and less evidence of clinical benefit in those patients specifically. We actually associate our SGLT2 inhibitors with a higher incidence of genitourinary infections. And one of the reasons behind this is because with these agents, we're seeing a larger excretion of glucose. And of course, our bacteria tend to love glucose and can infect these various areas of the urinary tract. These agents are also associated with a degree of volume depletion, so we need to make sure if we are initiating these agents that we are monitoring for that. And then also, especially since these agents were initially studied as anti-diabetic drugs, and we do know that it has been successful in lowering blood glucose levels, that we are adjusting medications appropriately if they're on additional medications for diabetes, to making sure that we're not pushing them into a hypoglycemic state. And with that, we have our second assessment question for today. So this is HL, and she is a 74-year-old white female with a new diagnosis of HFpEF. The patient's echo demonstrated a recent ejection fraction of 55%. Other pertinent past medical history includes hypertension, type 2 diabetes, as well as depression. And now the patient is presenting to the clinic for HFpEF medication therapy management. Based on various laboratory and vital assessments, the GFR was noted to be 62. Her blood pressure at the clinic today was 152/78. She does not have any drug allergies, and she has a weight of 86.2 kilos and then a BMI of 31.6. And she's on a number of home medications that you can see here, 2 of which are used for her diabetes with the metformin as well as the insulin. So based on the information that I have provided for you all, is this patient a candidate for an SGLT2 inhibitor? And if so, which agent would you recommend and what dose?
I would give answers, but that would be cheating because I have the answers.
I'll give it a couple seconds and then I'll give the answers away. Okay, I'll go ahead and state it. So yes, this patient would be a candidate for an SGLT2 inhibitor. So we could use either that empagliflozin or dapagliflozin at a 10 milligram dose, as that's typically the recommended dose for HFpEF. A couple of things that I thought about, I had highlighted in this patient's case. So we see this GFR was above that threshold where we would want to use caution since it was 62. We do know that they are presenting with PEF, since I kind of told you in the assessment question itself, but this could potentially be confirmed with that ejection fraction being greater than 50%. And another important thing to consider would be their diagnosis of type 2 diabetes. And with that being said, what are some clinical factors to consider if an SGLT2 is initiated? So some of the things that I thought about on that forefront as well is that renal function, which I had already mentioned, and there may be some potential to adjust the medications that they are on for diabetes, since they are on metformin and insulin. Now, just of note, there's no specific recommendations as to how much you would need to decrease an insulin dose if we were to start an SGLT2 inhibitor. However, my recommendation would probably to be conservative, at first, maybe just decreasing that glargine dose to maybe 9 or 10 units, and then from there, depending on how they respond, we could step that down even further if we needed to. All right. And with that, I'll go ahead and move forward to some of those additional therapies that I'd mentioned and what we could recommend in addition to our SGLT2 inhibitors. So to start off with our mineralocorticoid receptor antagonists, or our MRA agents, like the SGLT2 inhibitors, this is also mentioned in the 2022 heart failure guidelines for HFpEF. It's currently a class 2B recommendation. And at this point, they recommend initiating these therapies in all women, and then specifically with men who have an ejection fraction that's less than 55 to 60%, who are presenting with those symptoms of fluid retention. And we actually see that these agents have particular benefit in patients presenting with some sort of diastolic dysfunction. Kind of provide another visual for you all to better understand the mechanism of action of our MRA agents. So they're mainly affecting aldosterone. So we can see here that aldosterone is binding here, and we see a greater reabsorption of sodium in this case, and a greater excretion of potassium in this case. So it's actually acting as kind of like a backwards mechanism where sodium is getting reabsorbed and then the potassium is getting excreted. So when we block the action of an aldosterone, we actually see more excretion of the sodium, which kind of helps reduce some of that volume overload, especially since we know that water tends to follow sodium. But with that, we actually see a larger degree of an increase in potassium that is reabsorbed. So actually another classification or another name for these agents are potassium-sparing diuretics, largely because we do see a higher degree of potassium reabsorption when these agents are utilized. So there's the mechanism of action again. So thinking about our MRAs that are typically used in our patients with HFpEF, we have spironolactone as well as eplerenone. In terms of the dosing for spironolactone, typically an initial dose is around 12.5 milligrams daily, and the recommendation is to titrate that dose every 2 to 4 weeks as the patient is able to tolerate, to a target dose of about 50 milligrams per day that's divided in either 1 or 2 doses. With eplerenone, the initial dose is around 25 milligrams daily, and likewise, we can double that dose every 2 to 4 weeks to a target of 50 milligrams a day. Thinking about the contraindications for this class of medications specifically, they do not recommend, obviously, initiating these agents if they've had any previous hypersensitivity to this class. It's actually also not recommended in our pregnant patient population. And then also if patients present with a potassium that is greater than 5, since we do know that these are potassium-sparing diuretics that can increase your potassium even further. In terms of some additional precautions that we should think about with these agents, the recommendation is to actually avoid these agents if patients have a GFR that is less than 30, or if they have a serum creatinine that is greater than 2.5. There is caution in using additional agents that could potentially increase your potassium. So that can include, additional potassium supplements or some other hyperkalemia causing drugs, for example, our ACE inhibitors or ARBs. And there also is a risk of gynecomastia with the use of spironolactone specifically that we should keep in mind for our patients. I did want to present one of the clinical trials looking at the use of spironolactone for HFpEF patients. This is the TopCat trial. It was a phase 3 study that was conducted in patients with an ejection fraction that was greater than 45%, and patients had to be at least 50 years old, presenting with the signs and symptoms of heart failure to be enrolled in this study. And likewise, they had very similar endpoints that we saw with the Emperor Preserved and the Deliver trials. Again, they looked at that composite of CV death as well as hospitalizations for heart heart failure, and then looked at additional secondary outcomes by breaking down that composite endpoint even further. And in this study, they were looking at the use of spironolactone, initially started at a dose of 15 milligrams daily and then titrated up to 45, and they compared that to the placebo. And if you have any questions as to why that dose is slightly different, I was kind of confused by that as well. I don't have the best answer for you, unfortunately, at that time, since that's kind of a little bit different than what we would typically want to recommend based on their current dosing scheme for HFpEF, but just something that I wanted to highlight in case any questions came up later on. But thinking about the results of this study, they actually did not see a statistically significant decrease in that composite endpoint. But when they broke it down even further, they did see that there was that reduction in hospitalizations for heart failure that we had seen, likewise with our SGLT2 inhibitors. And so based on the results of the study of the TopCat trial, they did conclude that the spironolactone did result in a statistically significant reduction in hospitalizations for our HFpEF patient population. Into our next therapy, we have our angiotensin receptor neprilysin inhibitors, or ARNI agents. Like spironolactone and eplerenone, this is also a class 2B recommendation per the 2022 HFpEF guidelines, and it is recommended in all women regardless of their ejection fraction, and then men with an ejection fraction that's less than 55 to 60%. Actually considered a first-line agent in our patients presenting with HFrEF. You might be very familiar with these agents at this point, since we will commonly be initiating them in our HFrEF patient population. And as I'd kind of alluded to earlier, we could consider using an angiotensin receptor blocker or an ARB in place of an ARNI if there's some evidence of intolerance or some cost issues with an ARNI agent, since these agents tend to be way more expensive than what we would see with our ARBs. So getting into the mechanism of action of our ARNIs, it actually is a drug that contains two different drugs. So to start off with kind of the first mechanism of the first drug, we can see that there is this enzyme known as neprilysin. And if you look earlier on the slide in this larger gray box, you may recognize this BNP that we had discussed earlier. And that's one of those natriuretic peptides that kind of serve as more of a compensatory mechanism and has those vasodilatory effects that may be beneficial in heart failure, and we typically see those being elevated. So with neprilysin specifically, this is actually the enzyme that will inactivate BNP and turn those into inactive fragments. But we do know that that particular peptide has very beneficial effects in our heart failure patient population. So with the sacubitril component of the ARNI drug, that would actually inhibit the neprilysin enzyme. So we see an increase in the overall BNP to help promote those vasodilatory effects and the decrease in volume overload that we want to achieve with our heart failure patients. And then the second component of that is the use of an ARB agent, valsartan. So kind of for reference here, valsartan is inhibiting angiotensin 2, which typically that serves to cause vasoconstriction of the efferent arteriole of the nephron, which can increase pressure and volume as well. So when we use valsartan, we see more vasodilation in the efferent arteriole, which can help kind of offset that pressure. So getting into the dosing for ARNI agent sacubitril valsartan, the initial dose is at 24/26 milligrams PO/BID, and then we would titrate that dose every 2 to 4 weeks as the blood pressure is able to tolerate, and we would titrate that up to a target dose of around 97 to 103 milligrams BID. In terms of some clinical considerations that we want to think about, starting with our contraindications to this therapy, obviously any hypersensitivity to sacubitril or valsartan would be a contraindication to use. This agent is also contraindicated in patients with any history of angioedema. And then we would not want to initiate this medication if patients had a documented use of an ACE inhibitor within the last 36 hours. And this is because they actually saw a higher incidence of angioedema occurring if this were to take place. Certain precautions for use with the use of our ARNI include acute kidney injury, since we do see some slight elevations in serum creatinine with this particular agent. We also see some hyperkalemia occurring with this medication as well, and there's some hypotension that can occur. So definitely something that we want to monitor from a laboratory and a vital standpoint. Yeah, for the final clinical trial that I wanted to share with you all this afternoon, I have the Paragon HF trial. And this trial is slightly different than what we saw with the last 3 trials. It's actually directly comparing the use of our ARNI against an ARB itself. But likewise, it is a randomized double-blinded trial that was conducted in patients with HFpEF. And they also looked at some of those similar endpoints that we saw in the previous studies with the composite of CV death and hospitalization for heart failure. And then they broke those outcomes down even further once again. So again, we are comparing our ARNI agent as opposed to our ARB agent, valsartan monotherapy, and they actually found that there was no statistically significant difference between either of these therapies. There was reduction in hospitalizations, but when we compared these agents head to head, there was no significant difference. So you may be wondering, if there's really no significant difference, why are we recommending the use of an ARNI over valsartan, especially if it's a more expensive agent? We should be just using ARBs if that's the case. Well, one of the things that they additionally looked at in this study was a subgroup analysis of patients that had a left ventricular ejection fraction that was less than 57%. And in that patient group specifically, they actually saw a statistically significant reduction in that composite endpoint with favor of ARNI therapy. So when you think about that recommendation that they have listed in the guidelines as well, or where we would want to maybe initiate an ARNI agent with an EF that's less than 55 to 60%. That was kind of where this came from because of the subgroup analysis. So definitely an ARB is something we could consider since it does have favorable outcomes, but typically we want to prefer our ARNI agent in that case. Bringing up our diuretic therapy, that's kind of like our last therapy that we think of. We do know that this could be a very beneficial agent, especially in our patients that have evidence of fluid retention, as well as addressing some of that symptomatic management of HFpEF. To give some examples of the loop diuretics that we would typically use in a patient with HFpEF, typically we would use furosemide, bumetanide, or torsemide, and I do have the dosing available here for you on the slide for your reference, as well as what we could titrate up towards. But in terms of the overall benefit of our loop diuretic therapy on mortality and reduction in hospitalization, we actually do not know this information at this point, so we could conclude that if we were going to utilize these agents, they should largely be used for just the symptom management and not for any sort of cardiovascular benefit. And with that being said, we should be combining our diuretic therapy with other forms of GDMP, like our SGLT2s, our MRAs, or our ARNI therapies. And just for reference here as well, I don't have it listed here specifically on the slide, but thiazide diuretics could be considered as an alternative to be utilized for the symptomatic management of HFpEF also. And so that leads us to our final assessment question for this afternoon. So we have JL, who is a 62-year-old African-American male who's presenting to his cardiologist office for the management of HFpEF. This patient does have some complaints of persistent bilateral leg edema, and they also have a past medical history of hypertension, GERD, and hypothyroidism, and their last ejection fraction was found to be 57%. Their current weight is found to be 101 kilos. They have a BMI that's 30.2. Blood pressure is slightly hypertensive at 140/72. Heart rate and respiratory rate are normal, however. They're on a number of home medications, including empagliflozin at 10 milligrams daily, furosemide 40 milligrams daily, and then a number of other maintenance meds with levothyroxine and pantoprazole. So based on the information I've provided, which of the following medications the patient is already initiated on has shown benefit in terms of the reduction of hospitalizations for HFpEF? Is it A, empagliflozin, B, furosemide, C, levothyroxine, and D, pantoprazole? Yeah. Got an answer here in the chat. So yeah, empagliflozin would be the appropriate response in this case, since we do know that obviously levothyroxine and metformin do not have benefit in heart failure, and furosemide has not shown any benefit in terms of the reduction of hospitalizations, but we do have that evidence with our SGLT2 inhibitors. And with that being said, what are some additional medications that may also be of benefit for this patient in particular in terms of the management of their HFpEF? Go ahead. Yeah, there's a number of agents we actually could consider using for this patient specifically. So Sacubitril valsartan, starting off with that initial dose of 24/26 BID could potentially be beneficial. There is some evidence they may be a little hypertensive, and we know that that could help reduce some of that. So that might be an appropriate agent to start for them. And alternatively, we could consider an ARB depending if they have other issues going on that we're not aware of. And then I also have the MRA agent like spironolactone listed here because that could also be definitely an appropriate agent for this patient as well to consider. We don't know baseline labs at this point, so that'd be something we want to look at with their renal function as well as their potassium level to see if this is an in fact appropriate agent for them. But a couple of things to ponder on and think about when going forward and thinking about the most appropriate therapies. So good job. Oh, and I also have kind of this to kind of reiterate what we discussed already. So again, SGLT2 inhibitors should be the most preferred therapy for our patients. So we have additional recommendations with our loop diuretics, with our MRAs, with our ARNIs, and then alternatively with an ARB, depending on various patient-specific characteristics to consider. So lastly, I wanted to give a little bit more information on some of the non-pharmacologic therapies and then also some information on comorbidity management, as oftentimes patients have a lot going on and there's definitely some additional considerations that we need for these patients. So to start off with our non-pharmacologic therapy that is recommended, one of the major ones that we consider with our HFpEF patient population is sodium restriction, which has been found to be effective in reducing volume overload associated with HFpEF. And currently the AHA recommendation for sodium restriction is to decrease sodium by about 2,300 milligrams of sodium per day. Looking at overall exercise, oftentimes, our patients may be presenting with a level of exercise intolerance, but we do know that obesity has actually been associated with a much poorer prognosis in our heart failure patients. So the recommendation is that patients should engage in about 150 minutes per week of aerobic exercise or moderate intensity exercise as they're able to tolerate that. And they actually found that some moderate exercise has been beneficial in improving exercise tolerance and functional capacity over time in our HFpEF patients. Kind of discussing some of the various comorbidities that our HFpEF patients may be presenting with. So starting with the diagnosis of hypertension, this is actually considered one of the most common causes of HFpEF, and approximately 60 to about 90% of our HFpEF patients will also present with hypertension. And we actually see an increased frequency of heart failure exacerbations in our patients presenting with an uncontrolled blood pressure. So at this point, based on the AHA and ACC recommendations, a goal blood pressure for both patients with hypertension and HFpEF would be a blood pressure that's less than 130/80. In terms of some therapies that we could think about that would be preferred for managing hypertension as well as HFpEF, we would think about management with one of our with our ARNI agent, one of our ARBs or MRA agents, based on the data that we currently have available. With atrial fibrillation, we see a higher prevalence of AFib in those with HFpEF as opposed to HFrEF. And actually aggressive weight rate control with beta blockers, as well as our dihydropyridine calcium channel blockers like diltiazem, is typically avoided in those with HFpEF, but they could be considered based on various patient-specific factors and then other comorbidities that a patient may be presenting with. And obviously as well, anticoagulation would be preferred in these patients to reduce their stroke risk depending on that CHADS-2 VAS score and their overall risk of having a stroke. Into another comorbidity that patients may be presenting with, chronic kidney disease. We actually see that these individuals may be predisposed to increased diuretic resistance as well as fluid overload. And it's important to note that our ACE inhibitors, ARBs, MRAs, and as well as our SGLT2 inhibitors have actually been studied and have very favorable data for slowing the progression of kidney disease, specifically with those that have a GFR that is greater than 30 at that point. About patients presenting with coronary artery disease. This is a comorbidity that presents in nearly 50% of patients with HFpEF, and it may further contribute to some of those symptoms that we see in a patient with HFpEF, like the shortness of breath or the exercise intolerance. Now, of a note here, the use of a long-acting nitrate like isosorbide is actually not preferred in those with HFpEF and CAD, and this isn't because there's any sort of safety concern or contraindication, but they actually found that there's no additional benefit when a long-acting nitrate was added to this patient group specifically. So just something to make note of. And lastly, I wanted to provide some information on patients with type 2 diabetes. So it's actually been estimated that nearly 70 to 100% of patients with HFpEF actually also have a diagnosis of type 2 diabetes. And there's actually some different recommendations in terms of our A1C goal that we may want to achieve in our patients with both heart failure as well as diabetes. So typically what we think about based on the American Diabetes Association guidelines is an A1C goal that is less than 7%, but they actually have slightly higher goals depending on how patients may be presenting with, and that can include patients with HFpEF. So an A1C goal of about 7 to 7.5 is preferred in our patients with like a lower severity of heart failure. But for those with even a more advanced stage of heart failure, an A1C goal of around 8 to 8.5% may actually be reasonable for those patients as well. When we think about some of our preferred agents for type 2 diabetes in patients who also have HFpEF, definitely our number one therapy would be our SGLT2 inhibitors, bearing no contraindications for use, since there's favorable data for both disease states. And they've actually found with the use of our SGLT2 inhibitors that this results in around a 0.5 to 0.8% reduction in the A1C for our patients. In addition to SGLT2 inhibitors, again, we can use various other diabetes drugs that we have available, but we just would need to be cognizant with our SGLT2 inhibitors if we would need to adjust those therapies even further to avoid hypoglycemia. The guidelines or the expert consensus document that was published do have a few statements on encouraging a multidisciplinary approach among our clinicians. One of the things they mention is a better coordination of care among PCP as well as specialists, especially since multiple times our patients will have multiple physicians that they are seeing for their various comorbidities. So making sure that they have adequate communication among those care groups is very important for addressing these items and making sure we're adjusting our therapies appropriately. Another component of this could be addressing various barriers and access to care issues that patients may have. So seeing if they have adequate access to a pharmacy that they can actually afford their medications, or travel to make sure that they can get those medications and adhere to them appropriately. They do have recommendations for a team-based approach among our healthcare professionals, kind of going along with that coordination of care that I mentioned earlier. And they want to make sure that clinicians are understanding of patients' cardiovascular risks, not just with HFpEF itself, but with the various comorbidities that they may be presenting with, because there's oftentimes a lot of conflicting factors that may impact a patient's therapy. And lastly, one of the bigger things that they mentioned